फॉरेन बॉडी एस्पिरेशन। कल का पेशेंट था हमारा फॉरेन बॉडी। फॉरेन बॉडी एक्यूट एंड क्रॉनिक दो टाइप के आते हैं। एक्यूट इज सडन ऑनसेट, पिन पॉइंट हिस्ट्री, दे कैन टेल टाइम कितने बजे चोकिंग हुआ, choking and cupping, and since then this is the problem. Some long distance patient can come after 24 hours, referred patients can come after 24 hours, but generally all acute things come within 24 hours. Main problem is suffocation, obstruction in airway. Respiratory rate increased or normal. You count the respiratory rate. If it is appropriate to the age, then it is less likely to be foreign body. But respiratory rate has to be increased if there is foreign body which is obstructing airway. Child has to be in distress if he has acute foreign body. Intercostal indrawing, progressively subcostal, suprasternal, flaring of LNAG, accessory muscles of neck. Inspiratory distress, differentiate it from expiratory distress and asthmatic or bronchiolitis attacks. Asthma attack or bronchiolitis attack also can come with a history of few hours to few months, few days, one day or 2 days. Since yesterday or something. But asthma means bronchospasm. Bronchiolitis means bronchospasm. It has to be expiratory. Foreign body, inspiratory problem. So we have to identify whether the problem is inspiratory or expiratory. We confirm it is an inspiratory problem of sudden onset. On auscultation, air entry decreased on one side. If trachea is obstructed, both sides it will be decreased. If foreign body is in the left bronchus or right bronchus, accordingly air entry will be decreased. So you compare air entry on both sides. Decreased on one side, normal on other side. So difference between air entry indicates unequal air entry or equal air entry. If you mention equal air entry and inspiratory distress goes in favor of low respiratory tract infection rather than foreign body. Equal is generally not foreign body. Reduced air entry and normal air entry. Now we pediatricians have seen auscultated so many children's chest that what is vesicular breathing, we understand it. We understand the vesicular breathing by auscultation, and if it is reduced, then it is likely that there is foreign body. So reduced air entry, unequal air entry, respiratory distress, inspiratory distress. On inspection, you may observe shift of mediastinum. The sternomastoid muscle on which side the mediastinum is shifted becomes prominent in a proper neck position. Trachea is not central when there is shift of mediastinum. Apex beat and cardiac impulse. Inspiratory and palpatory finding. If there is shift of mediastinum to the opposite, to the right side, it will be shifted or may not be noticed. There is compensatory emphysema on the other side because of obstruction to airway on one side. So there will be hyper-resonant area on opposite side. That indicates emphysema on opposite side. That is an indication of emphysema. Next step is X-ray chest. It has to be standing. Lying down X-ray chest has no value in pediatrics. If any X-ray unit in your hospital is taking X-rays of children in lying down position, tell them not allowed. You cannot interpret a X-ray chest of a child in a lying down position. Finish. Nothing doing. It has to be in standing position. It has to be PA, posterior-anterior view. Even slight twist of a wriggling, struggling child can distort the image because it is a shadow, play of shadow. Posterior-anterior means tube is posterior and plate is anterior. AP view means tube is anterior and plate is posterior. So PA view with good centralization. Good centralization means both clavicles should look perfectly equal in the same position. If both clavicles are absolutely equal, it is well centralized. And clavicles are not equal, that is ill centralized. Well centralized PA standing view has value. Other X-rays are ornamental for generating income. No use for interpretation. Emphysema on one side, very dark air shadows as compared to the side where there is obstruction. If it is partial block due to foreign body, it acts like a ball wall mechanism. Inspiration is active process and inspired air goes into the lungs. Expiration is a passive process. It is at low pressure and that's why it acts like a ball valve mechanism and there is air trapping, and in partial obstruction there is emphysema on that side. In total obstruction, the air beyond obstruction is absorbed and lung is collapsed. So after collapse also there can be shift of mediastinum. So shift of mediastinum due to emphysema or collapse, we have to diagnose on X-ray chest. Once the diagnosis is confirmed, bronchoscopy, immediate bronchoscopy, emergency bronchoscopy is the answer. You give oxygen, stabilize the patient. Rigid bronchoscope is preferred over fiber optic flexible bronchoscope. The advantage of a rigid bronchoscope is that it is wide lumen and a larger foreign body can be removed, and there is a independent separate source of oxygen. Once you put the bronchoscope through larynx, oxygen supply to the lung starts immediately with separate and independent source of oxygen. In fiber optic bronchoscope or flexible bronchoscope, that facility is not there. Removal of foreign body instantly solves the problem, but the duration of foreign body makes difference. It can cause secondary infection, it can cause complications, it can cause bronchopneumonia, pneumonia and any sort of complication. So proper antibiotic management, proper complications, you should be cautious, conscious. Risks of bronchoscopy, trauma, hemorrhage, infection. Even after removal, after 48 hours, you have to watch the respiratory rate, pulse ox. Respiratory rate should be reducing, pulse ox should be maintained. Chronic foreign body, long term, few months to years, foreign body lodged, which is not completely obstructing, not even partially obstructing, but it is there. It is causing pathology locally. It presents with recurrent coughs, but there is reduced air entry. There is unequal opacity on X-ray chest. There is compensatory hyper, because in bronchopneumonias, you don't get very much compensatory emphysema. So sometimes chronic foreign bodies can be diagnosed only direct observation through bronchoscope. But it is a sixth sense diagnosis. You pick up by experience that no, we have to check one's bronchoscopy foreign body for this recurrent localized one-sided lower respiratory tract infections. So it comes in a differential diagnosis of recurrent LRTI at same lobe or same lung, and removal of the foreign body solves the problem. Because in such cases, recurrent admissions, recurrent antibiotics, sometimes anticox is given, and the basic cause is foreign body. You remove it and child gets cured. So that's how we have to manage foreign body, and it's a Sometimes it's an emergency, sometimes it is tricky. So all variety of patients of foreign body can come.